Scoliosis, the abnormal sideways curvature of the spine, is a condition that can affect anyone, regardless of age, gender, or background. Yet, one of the most striking and consistent findings in scoliosis research is that females are disproportionately affected, especially when it comes to moderate and severe curve progression. While mild scoliosis occurs relatively equally between boys and girls, girls are up to 8 times more likely to develop curves that progress and require active treatment. This gender discrepancy is not fully understood, but emerging science and clinical observations point to a complex interaction of genetic, hormonal, neuromuscular, and growth-related factors. Understanding the basics, types, and onset. To explore why scoliosis affects females more often, it's important to understand how scoliosis typically presents. The most common form, adolescent idiopathic scoliosis, AIS, emerges between the ages of 10 and 18. The term idiopathic means the cause is unknown, though recent advances have uncovered several contributing genetic and physiological factors. Both boys and girls can be diagnosed with AIS, but girls are far more likely to see curve progression. In clinical settings, this becomes evident as the curve increases from mild, 50 degrees, sometimes recommended for bracing or surgical intervention. The role of genetics. Genetic predisposition plays a substantial role in the development of scoliosis. Family history is often a key risk factor, but the way genes express themselves seems to differ by sex. Many of the single nucleotide polymorphisms, SNPs, associated with scoliosis, variations in DNA that can influence health and disease, affect estrogen metabolism, bone growth, and neuromuscular development, all of which function differently in females than in males. For example, variants in the ESR1 gene, which encodes the estrogen receptor, are more active in females and can affect how spinal tissues respond to hormonal changes during puberty. Similarly, SNPs in genes associated with bone density, connective tissue development, and melatonin signaling have shown sex-specific patterns in expression and impact. These differences may make girls more susceptible to the structural imbalances that allow scoliosis to develop and progress. Hormonal influence, estrogen, and puberty. Puberty is a critical period for scoliosis development, and it's during this time that girls begin to diverge significantly from boys in scoliosis risk. One of the main reasons for this is the role of hormones, particularly estrogen, which is more dominant in the female developmental process. Estrogen affects bone growth and the closure of growth plates. However, it also influences ligament laxity, muscle tone, and neurological signaling, all of which can contribute to spinal instability. As girls enter puberty earlier than boys and often have faster growth spurts, they experience a period where the spine is more vulnerable to distortion, especially if genetic and environmental factors are already at play. Interestingly, studies have also shown that girls with scoliosis often have abnormal levels or timing of estrogen secretion compared to their peers. This hormonal dysregulation could make the spine more prone to curving under the mechanical stresses of rapid growth. Skeletal growth patterns and bone quality. Another piece of the puzzle lies in the growth velocity and skeletal structure of females during adolescence. Girls typically grow faster over a shorter time span than boys, and this rapid skeletal elongation can outpace the development of muscular and ligamentous support systems. As a result, the spine becomes more prone to curving under even mild asymmetries or imbalances. Moreover, girls with scoliosis often show signs of lower bone mineral density, BMD, than girls without the condition. This makes the spine less resilient to compressive forces and mechanical stress, especially in the thoracic and lumbar regions. There is ongoing research exploring whether bone quality differences are a cause or a result of scoliosis, but what is clear is that reduced BMD is more prevalent among female scoliosis patients. Neuromuscular differences and proprioception. Females and males also differ in their neuromuscular coordination and proprioceptive function, the body's ability to sense movement, action, and location. These differences may contribute to scoliosis risk, as poor postural control and delayed neuromuscular development have been observed in many girls with scoliosis. Additionally, girls with AIS often show asymmetrical muscle activation in the back, abdominal, and spinal muscles. These imbalances can create torque or strain on the spine over time, allowing or exacerbating curvature. Again, these neuromuscular discrepancies are influenced by hormonal changes and genetic predispositions that disproportionately affect females. Melatonin and sleep cycles. Some researchers have explored the melatonin hypothesis, which suggests that a deficiency or dysfunction in melatonin signaling could play a role in the development of scoliosis. Melatonin is not only critical for sleep regulation, but also influences bone formation, balance, and neuromuscular control. Studies have shown that melatonin receptor abnormalities may be more common in girls with scoliosis. This could lead to disruptions in sleep cycles, delayed neuromuscular development, and impaired posture control, factors that may contribute to the progression of spinal curvature. Psychosocial and behavioral factors. While less biologically driven, psychosocial stressors and body awareness issues also tend to impact girls more than boys, especially during adolescence. Girls are more likely to be conscious of posture, weight, and body shape, sometimes leading to compensatory postures that mask or even worsen scoliosis. Anxiety, perfectionism, and stress, all more frequently reported in adolescent girls, have been linked with increased muscular tension and asymmetrical movement patterns. Although not direct causes of scoliosis, these behaviors may exacerbate curve progression in those already predisposed. Why doesn't scoliosis affect boys the same way? Given all these factors, why do boys tend to escape the higher rates of scoliosis progression seen in girls? The answer likely lies in the timing and nature of male growth, stronger muscle-to-bone ratios, higher bone density, and different hormone profiles. Boys tend to grow more slowly and over a longer period, giving their musculature and skeletal systems more time to adapt to changes in height and weight. Testosterone also promotes greater muscle development and denser bones, which can help support and stabilize the spine more effectively during growth spurts. Additionally, many of the genetic and hormonal factors implicated in scoliosis progression are either less active or behave differently in male biology, offering a kind of natural protection against curve worsening. A perfect storm of factors. The higher incidence and progression of scoliosis in females is likely the result of a perfect storm of interrelated factors: genetic susceptibilities, hormonal changes, rapid growth, lower bone density, neuromuscular imbalances, and even psychosocial stressors. No single factor explains it all, but together they create a biological environment in which scoliosis is more likely to take hold and progress in adolescent girls. Understanding these gender-based differences is more than a matter of statistics. It's a roadmap for better treatment. Recognizing that girls may need earlier screening, more personalized hormonal and nutritional support, and interventions tailored to their specific growth patterns allows for a more proactive and whole-body approach to scoliosis care. In this way, future treatments can not only be more effective, but also more equitable and preventative for those most at risk.